Trying to keep up with medical research, especially cancer research, it moves so fast it can feel like a full-time job.
It really can. Things change constantly.
Well, that's why we're here. Today we're doing a deep dive into some really interesting new findings on treating non-small cell lung cancer, or NSCLC.
Mm-hmm.
Our mission is to unpack the key takeaways from a specific important study. It's called the randomized phase 2 study of consolidation immunotherapy with nivolumab and ipilimumab, or nivolumab alone, following concurrent chemoradiotherapy for unresectable stage 4 IAIIB non-small cell lung cancer, NSCLC. Big Ten Cancer Research Consortium, LUN16
Quite a mouthful.
It is. But important stuff just came out this year, 2025, in the Journal for Immunotherapy of Cancer.
And it's a critical area. To
Right,
give you some context, about a third, roughly, of NSCLC patients get diagnosed at stage 3. It's locally advanced disease.
Okay.
And, despite real progress lately, the tough reality is that a majority of these patients, unfortunately, still die from their cancer.
Mm-hmm.
So there's this constant, urgent need for better strategies.
Right. The urgency is clear. So maybe let's set the scene first. What's the current standard treatment for these patients, the ones with unresectable stage 3 NSCLC?
Okay, so the standard is concurrent chemoradiation, that's chemo and radiation given together,
Right.
followed by a year, 12 months, of what's called consolidation immunotherapy, using a drug called durvalumab.
And that came from the Pacific trial, didn't it? That was a big deal.
Exactly. The Pacific trial was landmark. It showed adding that year of durvalumab really improved the 5-year overall survival, boosted it from about 33% up to nearly 43%.
That's a significant.
Huge. It changed practice.
So even with that success, there were still questions, things researchers weren't sure about. What was this new study, LUN16 trying to figure out?
Well, yeah, several big questions remained. One was, is that 12-month duration really the magic number for the immunotherapy? And could combining different types of immunotherapy maybe work even better than just using one drug like durvalumab?
Okay, so duration and combination. Let's talk about the duration first. Why question the 12 months?
Well, it's interesting because that 12-month time frame, it was somewhat arbitrarily chosen initially.
Really? Not based on specific data showing 12 months was best?
Not really strong data defining that exact duration as optimal. And here's something else in those big trials, like Pacific with durvalumab and another one with a similar drug, pembrolizumab. Many patients actually couldn't finish the whole year.
Oh, why not? Side effects?
Often, yeah. Immune-related side effects sometimes meant stopping early. In Pacific, only about 39% completed the full year. For pembrolizumab, it was even less, around 43%.
Wow, less than half.
Right. And what was intriguing was that some exploratory analyses hinted that patients who stopped early due to these immune issues sometimes did just as well as those who got the full year.
Huh. So maybe a full year isn't always necessary.
That's exactly the question. It suggested maybe we could achieve similar benefits with less treatment, which means fewer side effects, less time in the clinic, lower costs, all important factors.
Absolutely. That really sets the stage for why they'd look at a shorter duration in this LUN16 trial.
Precisely.
Okay, so let's get into the study itself. LUN16 what did it look like?
So it was an open-label, randomized phase 2 trial, multi-center, involving 105 patients.
And these are patients with that unresectable stage, IIA, or NSCLC, who'd already finished the standard chemoradiation part.
Correct. They'd done the first bit, the chemoradiation, then they were randomized.
Okay, and what were the treatment groups?
2 arms. Arm 1 got nivolumab, that's one type of immunotherapy checkpoint inhibitor, an anti-PD-1. They got it alone.
Nivolumab alone. Got it. And Arm 2?
Arm 2 got a combination. They received nivolumab plus another immunotherapy called ipilimumab. Ipilimumab works differently. It targets CTLA-4.
Okay, nivolumab plus ipilimumab, Nivo-Ipi.
Yep. And here's the key difference from the standard care.
The duration.
Exactly. Both of these regimens, the Nivo alone and the Nivo-Ipi combo, were given for up to 6 months.
6 months. Half the time of the standard durvalumab treatment.
Right. A really significant reduction.
So how did they measure success? Were they comparing the 2 arms directly?
Good question. No, it wasn't set up as a direct head-to-head comparison between Nivo alone and Nivo-Ipi. It was technically non-comparative in that sense.
Okay, so how did they evaluate them?
Each arm was compared against a historical control group, like a benchmark from past data.
Right. Makes sense for a phase 2. So what were the benchmarks?
For the nivolumab alone arm, the comparison was against getting just chemoradiation alone, sort of the old standard before Pacific. The historical 18-month progression-free survival, or PFS, for that was about 30%.
Okay, 30%. And for the combination arm, the Nivolumab.
That arm was compared against the current standard chemoradiation, followed by the 1-year durvalumab. The historical 18-month PFS for that is around 44% based on the Pacific data.
Got it. So 30% for Nivo alone benchmark, 44% for Nivolumab benchmark. And the main thing they were looking at was this 18-month PFS.
Yes, 18-month PFS was the primary endpoint. They also looked at, secondary things like overall survival OS, time until the cancer spread elsewhere, metastatic disease, and crucially, safety and toxicity.
Okay, makes sense. So, the big moment. Did this shorter 6-month approach work? Did these arms meet their goals against those historical numbers?
Yes, they did. And that's the really exciting news here. Both arms successfully met their primary endpoint.
Both, wow.
Both showed a statistically significant improvement in that 18-month PFS compared to their respective historical controls.
Okay, let's hear the numbers. How much better? Nivolumab alone first.
All right, for nivolumab alone, the 18-month PFS was 65.5%.
65.5, compared to the historical 30%.
Exactly. More than double. A really substantial improvement.
That's impressive. What about survival?
Median PFS for that arm was 29.7 months, so almost 30 months, and median overall survival was 32 months.
Okay, very promising for just 6 months of therapy. Now, what about the combination Nivolumab?
Also very strong. The 18-month PFS for Nivolumab was 66.3%.
66.3. And that was compared against the 44% historical rate for durvalumab.
Correct. So again, significantly better than that benchmark.
And the survival for the combo arm.
Median PFS was 26.3 months. And interestingly, the median overall survival, well, it hadn't even been reached yet during the follow-up period of the study.
Not reached. That usually suggests patients are living longer, right?
It often does, yes. It's a very positive signal.
So, taking these efficacy results together, what does this tell us about that duration question? 6 months versus 12.
Well, what's really striking is that the median PFS numbers we just talked about, almost 30 months for Nivo alone, over 26 for Nivolumab, these compare really favorably to what we've seen in prior consolidation trials that used a full year of treatment.
Even though it was only 6 months here.
Right. Now, this study wasn't designed to prove that 6 months is equivalent to 12 months head-to-head. We need larger phase 3 trials for that.
Sure.
But these results strongly, powerfully suggest that the optimal duration isn't set in stone at 12 months. It might well be shorter for many patients.
That could be huge for patients. Less treatment time.
Huge. Think about quality of life, fewer side effects potentially, fewer trips to the hospital, lower costs. If we can get similar or maybe even better results with half the treatment, that's a potential game changer. Definitely warrants more investigation.
Absolutely. Okay, so the efficacy looks really promising, but treatment isn't just about effectiveness, it's also about side effects. How did the safety profiles compare?
Right, always the crucial balance.
Yeah.
So if we look at overall treatment-related adverse events, or TREs, any grade,
Okay.
it was about 72% for nivolumab alone, and a bit higher, 80% for the nivolumab combination.
So slightly more common with the combo. What about the more serious ones, grade 3 or higher?
That's where you see a bigger difference. Grade 3 or higher TREs were seen in 18.5% of patients on nivolumab alone.
Okay, about 1 in 5.
But it jumped to 29.4% for the nivolumab combination, almost 30%.
Noticeably higher toxicity with the combination then.
Yes, clearly indicating more toxicity there. Common things reported across both arms, especially the more significant ones, included fatigue, lung inflammation or pneumonitis, rashes, shortness of breath, thyroid problems, typical immunotherapy side effects.
You mentioned pneumonitis. That's often a concern with these drugs, isn't it?
It is. It was an adverse event they watched closely in this study. Interestingly, the overall rate of grade 2 or higher pneumonitis was pretty similar between the arms, around 20% in both.
Oh, okay.
But when you look specifically at the more severe grade 3 or higher pneumonitis, that was more common in the combination arm. It was 11.8% with Nivolumab versus 7.4% with Nivo alone.
I see. So more severe lung inflammation with the combo.
Yes. And it also tended to develop a bit earlier in the combination arm. Average time was about 8 weeks versus nearly 12 weeks for the Nivo alone arm.
Was it manageable?
The good news is, yes, generally. They reported that nearly all patients who developed pneumonitis recovered pretty quickly with supportive care, things like steroids. And importantly, there were no grade 4 or 5, the most severe, potentially fatal pneumonitis events reported.
That's reassuring.
It is. However, that increased toxicity overall in the combination arm did translate into other issues. Patients on Nivolumab had higher rates of needing hospitalization, almost 20% versus about 11% for Nivo alone.
Okay.
And more patients had to stop treatment early because of side effects, nearly 30% in the combo arm compared to about 18% in the Nivo alone arm.
So there's definitely a trade-off. The combination might offer that edge in efficacy against the durvalumab benchmark, but it comes with a higher price in terms of toxicity and treatment discontinuation.
Precisely. It's that classic risk-benefit calculation that doctors and patients have to weigh.
Okay. Beyond these main efficacy and safety findings, you mentioned the study had some exploratory analyses looking at subgroups.
Yes, and this is where things get even more nuanced and honestly quite fascinating, even though we have to be cautious because the numbers in these subgroups are smaller.
Understood. What did they look at? You mentioned PD-L1 status earlier.
PD-L1 is that biomarker, protein on cancer cells, that sometimes predicts response to immunotherapy. So the nivolumab alone arm, they found something interesting. There was no real difference in PFS or overall survival, whether patients had high or low PD-L1 levels. Benefit seemed similar regardless.
Huh. But didn't the Pacific trial with durvalumab show the benefit was mainly in PD-L1 positive patients?
Exactly. So this finding kind of contrasts with that prior Pacific data. It suggests maybe nivolumab alone works a bit differently in this setting, or perhaps PD-L1 isn't the whole story for predicting benefit from it here.
Interesting. What about the combination arm, nivolumab and PD-L1?
Here, the pattern was different again. In the combination arm, patients who were PD-L1 positive did seem to do better. They had numerically higher PFS and statistically significantly better overall survival compared to the PD-L1 negative patients in that arm.
So PD-L1 mattered for the combo, but not for Nivo alone in this study.
That's what this exploratory analysis suggests.
And is that what you'd expect? How does that compare to other studies of this combination?
Well, that's another twist, because some previous studies of anti-CTLA-4 drugs like ipilimumab, especially in metastatic cancer, have actually suggested they might provide more benefit in the PD-L1 negative group.
Wow. Okay. So it's really complex and maybe context dependent.
Very complex. It really highlights that we still have a lot to learn about how these biomarkers work with different drugs and in different stages of cancer.
What else did the exploratory analyses look at?
Another really interesting one was the timing. When do patients start the immunotherapy after finishing their chemoradiation?
Does starting sooner rather than later make a difference?
You'd think maybe right. Get the immune system boosted quickly. But this study's analysis didn't show better outcomes for starting earlier.
Really?
Yeah. In fact, for the nivolumab alone arm, there was actually a trend numerically higher PFS and OS for patients who started later, specifically more than 4 weeks after finishing chemoradiation.
Later was better. That seems counterintuitive.
It does. And again, it kind of contradicts what was reported from the Pacific trial, where earlier initiation seemed slightly better. However, it does align with some other studies that also didn't see a benefit for starting very early.
So the jury's still out on the optimal timing, too.
It seems so. Maybe allowing some recovery time after chemoradiation before hitting the immune system again is important, or maybe it's more complicated than just sooner is better.
All these nuances, even from exploratory data. What's the big picture takeaway from them?
What's fascinating here, I think, is how these details, the PD-L1 variations, the timing questions, they really push us towards thinking about more personalized medicine.
Right. Not one size fits all.
Exactly. It underscores the need for better tools, better predictive biomarkers beyond just PD-L1, perhaps. Things like circulating tumor DNA, ctDNA, which is basically looking for tiny bits of tumor DNA in the blood.
How could that help?
Well, imagine if we could use ctDNA or other markers to predict much more accurately who is likely to relapse after chemoradiation, who would benefit most from adding immunotherapy, which type of immunotherapy might be best, and importantly, for how long they actually need it.
Tailoring the treatment duration and type to the individual patient's risk.
Precisely. That's the goal. Using these powerful tools to potentially predict relapse risk and personalize the consolidation strategy duration, drug selection for each patient. That's where research like this, digging into the nuances, is ultimately heading.
Okay, so let's try and wrap this up. Recapping our deep dive into the LUN16-081 study, what are the main headlines?
Well, first, it definitely reinforces the value of adding consolidation immunotherapy after chemoradiation for this group of patients.
Right, the concept holds strong.
Yes. But the really big news is the promising results with a much shorter 6-month duration for both nivolumab alone and the nivo-AP combination. Both significantly beat their historical benchmarks.
But we also saw that the combination, while effective, came with a higher rate of serious side effects and treatment discontinuations.
Correct. That efficacy-toxicity trade-off is very clear, especially with the combination.
So how does this fit into the bigger picture? Does this change practice tomorrow?
Not immediately, no. This is a phase 2 study. The current standard of care, based on the larger phase 3 Pacific trial, remains 12 months of durvalumab.
Okay.
But the study provides absolutely vital information. It strongly informs how we should design the next generation of clinical trials. It puts the question of optimal duration front and center.
Suggesting maybe 12 months isn't the only answer, or maybe even the best answer for everyone.
Exactly. It pushes us to formally test shorter durations in larger trials.
Yeah.
And it also gives us clues about patient selection. Maybe PD-L1 isn't the only marker. Maybe timing matters differently than we thought. It helps refine the questions for future research.
So it's a really important stepping stone.
A very important one.
And just thinking ahead, imagine, as you were saying, a future where we could use a patient's own unique biological markers, maybe ctDNA, maybe something else, to tell us precisely, okay, for you, this immunotherapy for this many months is the best approach.
Maximizing the benefit, minimizing the side effects, and the burden of treatment.
That really is the frontier of personalized medicine that this kind of research is driving us towards.
It is. It's a continuous process, learning from each study, refining our approach.
It definitely makes you appreciate the ongoing scientific effort, the dedication to constantly improving how we treat complex diseases like cancer step by step.
Absolutely. Each piece of research adds to the puzzle.